Hi, I'm Shayma Kazmi. I'm a thoracic oncologist at CTCA. People with intact immune systems can fight off most infections, and they may have mild to moderate symptoms to any infectious diseases. When you're immune compromised, your immune system is not working at its full capacity. Lots of diseases can lead you to be immunocompromised, diseases of the immune system, cancers, and other chronic rheumatologic conditions where your immune cells are affected. Lots of medications can also depress or lower your immune system's ability to fight ongoing infections. And that some of that is intentional so that the treatments are trying to also clamp down the overactive immune system that may be causing some of the inflammation in the body. Cancer is a very broad diagnosis. So it can range from a very early in situ cancer that was removed in its entirety and does not pose any real medical ongoing threats or does not lead to any immunocompromised state. But there is multiple variations of that. So you could have cancer that was advanced stage that is now in remission, or you're cured of it and you're in surveillance, or you could have active cancer. So in the worst case scenario, if you have active cancer for which you're undergoing treatment, your immune system is absolutely compromised. Now, depending on where that cancer is, it could be that your lungs are compromised more so, and you may be higher risk of lung complications, or your heart, or some other organ that's vital to you. But if you have had cancer a few years ago and you're really on surveillance and you finished your therapies a few years ago, you should believe that you have relatively intact immune system, barring any other medical conditions. So for patients who are on oral cancer therapies, they need to understand that their immune system is still going to be compromised. And this is a very individual discussion between the patient's health status, their benefit from continuing therapy, and their potential risk. So it's best done with the patient's treating physician. However, as a general rule, what I've changed is instead of having in-person visits of patients who don't need to travel, converting to telehealth visits, also being able to do blood work to ensure safety of the next cycle of therapy closer to home so they don't have to travel to the cancer center. And that's really how we're adapting to these patients. As education piece in these telehealth visits, I also emphasize to these patients the best way they can keep infection rate as low as possible in their case, and what to do if they do need to leave the house for shopping, for instance, and washing hands and avoiding contact with other people unless necessary. So that's also an opportunity to educate them. There's a lot of misinformation and confusing information out there, and it's important for them to hear from their physician what the safest thing for them is. And also, for some patients, the risk of discontinuing therapy would be potentially fatal. These are cancer patients. So treatment continuation in a safe way is important. I can't emphasize this enough. Of course, every patient, their current cancer diagnosis and their clinical status has to be weighed when making any decisions. And to that point, ASCO has set forth a set of guidelines, but really the treating physician is the one who has to advise the patient on the best course of treatment. There are patients who have a very, very small lesion, who may be in early stages of a slow growing malignancy, who may be able to safely wait 4-6 weeks prior to a curative therapy. On the other end, however, if you have a patient with an aggressive lung cancer, for instance, who, if they waited 4 to 6 weeks, would no longer be resectable or curable, you're really harming them in the long run by delaying therapy. So this really boils down to which procedures may be safely held off for more than 3 months, which procedures can be held off for 30 days, and which procedures should be done as soon as possible, also knowing that there are no set date when this crisis abruptly ends. So this is going to be a long discussion. I would say that every patient should discuss their individual case with their oncologists. What I have done in my practice is it truly depends on their stage of cancer and their likelihood of recurrence and where they are in their cancer journey. For instance, if you're 5 or 6 years out of your early cancer journey, the risk of recurrence at this point, if you're completely asymptomatic, is small enough that you can delay that scan a few months without any detriment to you, or missing a potential recurrence. And so that's different from someone who may have had a relatively advanced stage cancer, stage 3 and beyond, who was recently treated from a curative potential and remains a very high risk for the next 3 to 6 months to a year for recurrence. So those have to be weighed separately. When I talk to these patients, I try to establish where they live, what the condition is in their state at this time, and if it's safer for them to get imaging done where they are locally versus coming in and traveling into their cancer center, and then obtaining the images via mail. There are ways to adapt and try to sort this out.